Okay, my name's Dr. Hopkins. How are you doing? I'm going to discuss today a little bit about demystifying lower extremity swelling. It's a really common problem, and so I decided to do an educational video to teach my patients about, what causes swelling and what we can do about it. So let's get started. Okay, so I'm going to go over a few things in this video. It's kind of long. You might want to get some popcorn. Longer than one of my usual education videos because there's just a lot to cover. So I apologize for that in advance, but hopefully when you come in to see me for your appointment, based on looking over this video, you'll already know what's wrong, and we can go ahead and really focus on treatment plans. So it'll help you with self-diagnosing your swelling issues. So we're going to go over a little bit about the definition of swelling and edema. We're going to talk to you about the different causes, what we call the pathophysiology, what causes it, and then how we assess people or patients with lower extremity swelling, and also go over the treatment. Okay, so I'm going to give a little bit of a swelling lecture with a venous and a lymphatic and a lipedema spin, and we'll go over what that means in just a second, because those are the things that I primarily treat. Edema and swelling is, there's a whole host of things that cause it, as you'll see in this video, and some of the conditions that cause swelling I treat and some I don't. So as a venous and lymphatic medicine specialist, I focus on the primary cause of swelling, or one of the most common causes of swelling, which is venous disease and lymphatic disease. So first of all, what is the difference between swelling and edema? Well, swelling is what the patient complains of. It's a subjective complaint. Okay, they state that their leg is swollen, and it's really the same thing, except for an edema is when you're examined by your provider, or you examine yourself and you notice that there's fluid within the leg, and that's abnormal. So they're pretty similar. It's just a subjective complaint versus an objective sign. So swelling is essentially a transient abnormal enlargement of a body part, not due to cell proliferation. It's actually fluid within the leg, essentially. And an edema is a condition of abnormally large fluid volume in the tissues themselves. The capillary filtration rate, which is how much fluid goes through the capillaries in your body, exceeds the ability for the leg to drain through the lymphatic system, and that causes edema, okay, which is fluid in the legs. So these are almost a complete, but not a complete list of all the different conditions that can cause swelling, okay? I focus in my practice on treating people and patients with venous causes as well as lymphedema. My board certification is in venous and lymphatic medicine. And included in that is a condition we call lipedema, which I'll discuss is not really edema. It's more of a fat maldistribution problem. But medications, heart problems, lung, liver, kidney, cancer, hyperthyroidism, or endocrine problems, all cause swelling. In addition, dependent edema is a condition we'll talk about, as well as idiopathic and premenstrual edema. Inflammation or trauma can cause swelling, as can infections or cellulitis. So we'll go over all of those conditions today. Okay, so this is our office in Sonora, and that's where some of our patients come. We also have an office in Jackson. So medications can cause, a lot of medications can cause swelling and edema. This is a list that's fairly inclusive, but probably the most common one really is amlodipine, which is given for high blood pressure. And that's one of the most common medications that actually will cause swelling. Now, heart failure, or congestive heart failure, we call it, that's a condition where the heart does not pump properly. Sometimes it can be enlarged and sometimes not, but if the heart is not pumping as much blood as it should be, then that can cause failure, and that can lead to swelling of the legs. It can present with what we call jugular venous distension, which is right here. The veins become distended, and then it causes lower extremity, what we call pitting edema. So you can see when you push your finger on the leg, you can see that and then you remove the finger, you can see that edema persists for at least a while, a few minutes afterwards. And so that's the way we can examine patients with heart failure and see that is sometimes the case. Now, there are a lot of symptoms to heart failure. This is way beyond the scope of my practice, but when you see your internal medicine primary doctor or your cardiologist and such, they'll review, and I will too to some extent, to figure out if heart failure might be a contributing cause. But you get short of breath, you get tiredness, you have weakness, fatigue, you get swelling. It's one of the common things, is swelling in your legs. So heart failure is common. It can present with a real rapid heartbeat. You can have difficulty exercising. You can have a cough. You can cough up pink kind of blood tinged sputum, and that's when it's more in its advanced stage. Sometimes people in heart failure have to void frequently, and they sometimes get abdominal fluid within the abdominal cavity. So these are the typical symptoms that we see in patients with heart failure, and that's a common cause of swelling. So sleep apnea is actually it's one that's under-recognized. It's frequently a cause of lower extremity swelling. And so patients that have sleep apnea, they usually are diagnosed by their partner if who sleeps with them, because they notice, as here, she's miserable because he's snoring, and this is really common. And snoring, daytime somnolence, you get really tired. Sometimes driving, it's really bad if you fall asleep at the wheel. Typically, patients oftentimes have a very enlarged neck circumference, over 17 inches is typical of someone that might have sleep apnea. And it causes leg swelling. Sometimes leg swelling can be the patient won't even know they have it until they notice that their legs are swollen, because let's say they're single and they don't have a partner that watches them snore and have these long periods of where they don't breathe. We call that apnea. It's very disturbing to the partner, so they'll definitely notice it, and you don't want to blow that off. That's something that's easily just kind of denial. Especially the men. We tend to deny this condition. So you don't want to deny it. You want to address it, and you want to get a sleep study, because otherwise, if you don't, it causes pulmonary hypertension, and I'm going to talk about what that is. So if you see over here, here is when this is what happens when you have inflammation. What happens, I should say, is you get nitric oxide. You get a drop in the nitric oxide synthesis because of intermittent low oxygen levels, because your tongue falls to the back of your throat and you don't breathe for intermittent periods of time, so you become hypoxic, which means you have a low oxygen level. That causes the decrease in the nitric oxide synthesis, and that then in turn causes inflammation of these arteries in the lungs. And when they become really inflamed, then they can impair the flow, and you end up getting a backflow of blood, which causes lower extremity swelling. So sometimes patients who have this condition, that's their first symptom is swelling of the legs. And you want to get that worked up by your cardiologist or your primary doctor. They'll typically do a sleep study. They'll do an echocardiogram if they want to look to see if you have this pulmonary hypertension thing. But this can be life-threatening. It can cause a lot of problems if untreated. So if your spouse or your sleep partner tells you that you are not breathing normally, you need a sleep study. That just needs to be done. So, and it can save your life in addition to improve your swelling. So both, pulmonary hypertension from sleep apnea and heart failure, they both can cause leg swelling, and it's not at all uncommon for patients to complain of leg swelling before any of the other clinical manifestations of these conditions occur. So that can be the first one. So keep an eye on that. So the liver can also cause leg swelling or edema. And usually that occurs as a result of cirrhosis of the liver. It's usually as a result of either alcohol, the toxins from alcohol abuse or use, excessive use, the toxins can damage the liver and cause cirrhosis, or viral hepatitis can cause cirrhosis as well. So this is what a cirrhotic liver looks like here, a very damaged liver from, again, usually either hepatitis or alcoholic cirrhosis. This is a normal liver. And cirrhosis, when you get cirrhosis, it can cause a lot of problems. Either your spleen can get really enlarged, it can get as big as this, okay, as a result of the cirrhosis, because there's a lot of back pressure, and the blood can't drain out of the spleen as well. And then you get fluid accumulation. This is called ascites. Fluid, so sometimes you get a big abdomen because there's a lot of accumulation of fluid within the abdominal cavity. So here's ascites, and then you can also it can present with these dilated veins because this is called caput medusa, and it's dilated veins within the abdominal wall because the blood is trying to find accessory routes to get back to the heart and the lungs, and sometimes it does so through the abdominal veins. So these become engorged and distended. It can cause, and frequently does cause, jaundice, which is a yellow discoloration of the skin, and also yellow discoloration of the sclera, the white part of the eyes. Those can turn yellow, and so that's called jaundice, and that can be an indication for cirrhosis. It can cause these little spider angiomas on the skin. That's a characteristic feature of cirrhosis. And then these little, I have a hard time pronouncing this, but it's Merkel's nails, and you can see this characteristic pattern on the nails, and that's not uncommon in patients with cirrhosis. But last but not least, cirrhosis can present as swelling or edema in the legs, and so that's the other cause. Now, kidney disease or nephrotic syndrome is also a condition that can cause lower extremity swelling and edema, and essentially the kidney spills a lot of protein and into the urine, and that's what causes this peripheral edema. Okay, and it also causes ascites. So, unlike some of the other conditions, kidney disease usually causes swelling not just in the legs, but kind of swelling and edema in the arms. Kind of everything's kind of puffy. The whole body's kind of edematous. So that's one characteristic feature of kidney disease. And here's the kidney, and this is where the filtration occurs, and you spill out a lot of protein in the urine. That's called nephrotic syndrome, and that's a cause of lower extremity swelling. But again, it also causes swelling throughout the body. Cancer, this is an uncommon cause of swelling, but it has to be considered. And this is a type of a malignancy in the abdominal cavity, and anything that any tumor or malignant tumor that infiltrates the lymph nodes within the abdominal cavity can impair the lymphatic flow through the lymphatic system, and that can cause swelling or lymphedema. And so cancer needs to be considered, although it's a lot less common. You can have what we call pretibial myxedema from thyroid disease, and it's a condition where there's this hyaluronic acid deposition in the skin that causes inflammation and swelling. It's not too common, but it's almost always associated with Graves' disease, hyperthyroidism, and so that is one of the less common causes for swelling. Dependent edema is not that uncommon. It's most typical in patients that just aren't ambulatory. They're not up and moving around. Like typical would be in a retirement home where you're in the wheelchair a lot. You're not able to move as much, and your legs are always in a dependent position, sitting in the wheelchair, and you end up with this edema in the legs. And it's just really our calf pump here is designed to function frequently. We use this calf muscle pump to pump the blood back up and the lymphatic fluid back up through our legs. And when that mechanism isn't activated frequently, like if you just have your legs down and and are in the dependent position, then that will cause this. And sometimes it can be a completely normal leg, but if you don't use your calf muscle pump, you can get dependent edema. Idiopathic edema is it's idiopathic, so by definition we don't really know what causes it, but it's associated with fluid in the face and the hands and the limbs. It's in women, and it's always in women, and it occurs in premenopausal women. So premenopausal women that have swelling, and in the absence of any heart, lung, liver, kidney problems, then that would be probably what we call idiopathic edema. Pregnancy can cause swelling and edema. The baby, pushes down on the drain. This is the inferior vena cava, which is the main vein that drains the legs. And when the baby pushes on this onto the spine, it can impair the flow, and you can get underlying pressure in the veins, and that can cause transient swelling. And most women know that when they're pregnant, especially the larger they get with their baby, they have more problems with swelling of the legs. And this is one of the reasons. And also there's a lot of hormonal changes that go along with pregnancy that can cause the veins to dilate, become engorged, and cause swelling as well. So other reasons that people get swelling is just inflammation from some reason, either from inflammation from a bacterial infection. This is a bacterial cellulitis. There's bacteria growing in this tissue. Probably this patient has underlying lymphedema, and then they have developed associated bacterial infection associated with that. But the bacterial infection will definitely cause a worsening swelling on top of the lymphedema. And then trauma. This is a patient of mine that banged her leg on a stationary object, a table, and this is all bruising and swelling. And this leg is it's almost twice as swollen as the opposite leg, and it's all just because of blunt trauma. They just if you get beat by a baseball bat, or you kick a table, it'll cause swelling. So any inflammation can cause swelling. And this is a swelling just from surgery. This is a total knee replacement, and just the surgery itself can cause swelling. There's other risk factors that go along with this type of surgery that can cause even more swelling, like deep vein thrombosis and that sort of thing. But we'll go over that in just a little while here. So obesity. Obesity itself is not, in and of itself, is not associated with swelling or edema. But obesity is associated with other medical conditions like sleep apnea, venous reflux, lymphedema, and idiopathic edema. So obesity is associated with these conditions, and these conditions are also associated with edema and swelling. So it definitely helps to do what you can to reduce your weight. And I am a strong, avid supporter of whole food, plant-based diet. That is a whole nother lecture, but if you go to my website on motherlodeVeinInstitute.com, I've got a nutrition section in the services link, and there's a lot of links to multiple websites. And this movie I try to preach to all of my patients that come into the office as much as I can, because it really goes over in a very simplified way how to change your lifestyle to a whole food, plant-based lifestyle. And it's not just swelling that it helps. I mean, it helps you with virtually every chronic condition that we suffer from in the Western world. The things that kill us too: diabetes, hypertension, heart attacks, stroke, cancers. I mean, the list goes on and on. So anyway, I would recommend whole food, plant-based diet. And if you want to learn more about that, go to my website under my services nutrition link. And okay, so this is the good stuff. This is what I treat primarily in my practice, and it's we're going to talk about venous causes for lower extremity swelling complaints and edema. So venous reflux is when the valves in the veins don't close and the blood goes in the wrong direction. And when that occurs, then it causes increased distension of the veins, and it causes a lot of things to occur, which we'll go over later. But venous reflux is one of the common reasons people, and is probably the most common reason people get swelling. It can occur in the superficial veins, it can occur in the deep veins, it can also occur in both, combined. So you have leaky valves, which is venous reflux, that can cause edema, and you can also have an obstruction. Two different ways you can have obstruction. You can either have a clot that can obstruct a vein, okay? That's called a deep vein, or if it's in the deep system, it's called a deep vein thrombosis, or you can have a clot in the superficial veins, which is much less serious. And that can cause edema, although less likely to cause significant lower extremity edema. We have lots and lots of other collateral veins in our superficial system that can take over even if some of them have clot in them. That's not the case for the deep system. When you have a deep vein thrombosis, that usually presents with swelling complaints and edema. So post-thrombotic syndrome is a condition that occurs with pain and swelling in the leg after a patient's had a clot in their leg, because sometimes only about 50 to 60% of the time that clot that has occurred recanalizes or opens up again, and when it doesn't, you can be left with chronic symptoms of pain and swelling. And also that clot can sometimes damage the little one-way check valves in the veins, and that can cause venous reflux where the blood goes in the wrong direction. And when that occurs, you get, or either one occurs, either the clot that stays there or the leaky valves, you can get post-thrombotic syndrome, which is essentially pain and or swelling in the leg, which occur on a chronic basis, sometimes lifelong, after a patient's had a deep vein thrombosis. And then there's this non-thrombotic iliac venous lesion, which I'm going to go over in more detail as to how that works. You can have both. You can have a clotting problem as well as a venous reflux problem. And then you can have a clotting problem and a venous reflux problem and, cirrhosis or sleep apnea or one of the other non-venous causes that I just talked about. So there's all kinds of, there's nothing to say that you only have one reason for swelling. Sometimes it's what we call multifactorial. In other words, sometimes multiple things are going on at the same time. So it can be very challenging to figure out. So this is venous reflux. I want to emphasize that it affects lots and lots of people. Just to give you a perspective, 30% of the population have venous reflux, but only like 1% have heart failure. So it's pretty common. And it actually is the most common cause of leg edema in older adults. You can take fluid pills or diuretics, but venous reflux, if this is the only cause for the swelling, venous reflux is not a fluid volume overload kind of a condition. So although it might help for a little while, long term it can cause some metabolic problems. So it's not recommended unless you have other reasons to be on the diuretics. Venous reflux, as you can see, it's a mechanical problem, right? There's valves that aren't closing over here in the diseased vein here, and when those valves don't close, the blood goes this direction down toward the feet, and that causes the veins to distend, and it causes the varicose veins to occur, and it causes aching, pain, heaviness, itching, burning, swelling, cramps, and edema. So that is venous reflux. So what are the symptoms? Like we just talked about, aching, pain, heaviness, fatigue, itching, burning, cramps, restless legs. That's not the only thing that causes restless legs, but it's one of the common reasons people get restless legs from all these refluxing veins here. And as you can see, this patient has some degree of swelling or edema. So what is the spectrum of venous reflux disease? Well, it can present initially with just little tiny spider veins. Usually these are asymptomatic. They just are cosmetically maybe unappealing. Then you start to get reticular veins, these little blue reticular veins. small varicose veins. And then you get more true bulging varicose veins. These are over 3 millimeters in diameter. And these are true varicose veins, okay? These usually have symptoms. Men tend to be less symptomatic than women, but patients with this type of physical exam usually have at least aching pain, some heaviness. And it's always worse when you're standing or sitting, and it's better if you elevate or if you wear compression stockings. But, and then as it progresses, you can get this ankle flare, which is another name for this is corona phlebitictica. And that has a high degree of association with venous reflux through the vein that goes right up in this location, which is called the great saphenous vein. And it goes all the way up and empties into the deep vein up in the groin. So this is called corona phlebitictica. And then as we mentioned, venous reflux can cause swelling. Now, if you only have venous reflux in your superficial veins, like your small saphenous vein, which starts here and empties into the deep vein here, or your great saphenous vein, which starts at the ankle and goes up and empties into the femoral vein up here. If you only have venous reflux through those veins, then that usually doesn't cause this degree of swelling. When you have this degree of swelling, it might cause mild ankle swelling, but usually no more than that. So when patients have this degree of swelling, we know that something else is going on beyond just superficial reflux. So either they've had a blood clot, or they've got lymphedema, or they've got sleep apnea. But usually when it's unilateral instead of bilateral, it's usually something related to this leg and not this leg. So it's either usually lymphedema or obstruction from a clot or deep vein reflux, something directly related to this leg and not a systemic disease. So when venous reflux gets really more advanced, I should say, you start to get this what we call lipodermatosclerosis. It's a little bit here, but it's more prominent on this leg. And you can see the chronic inflammation occurs. So we don't know exactly the mechanism. We know it's a leukocyte or white blood cell mediated kind of an inflammatory process. But nonetheless, it occurs as a result. This is characteristic of venous reflux and no other condition. And so when we see this condition, we're fairly confident that usually there's some underlying reflux, either in the superficial or the deep system, but this is a characteristic of venous reflux. And again, it's a chronic inflammation that occurs. You can also get pigment changes, like these kind of pigment changes in the skin. That's called hemosiderin pigment changes, these bulging varicosities. And then as it progresses further, you get that same lipodermatosclerotic skin. You can get venous eczema. And then eventually you get a venous stasis ulcer, and this is an active ulcer. It's a small one, but it's still an ulcer. And then they can be as big as this, where they get these big, large venous stasis ulcers. And this is all a result of the inflammation that occurs as a result of the venous reflux, which has not been treated. So we want to treat this condition early to prevent this type of problem from progressing. So lipodermatosclerosis, I talked to you a little bit at the last slide, and you can see this is that lipodermatosclerotic fat tissue, and it's called the bottleneck deformity because you can kind of see it looks like the neck of a bottle, and basically you have this exaggerated contouring of the calf. So the contouring of the calf to that little bottleneck is exaggerated, much more so than usual. This one has much less exaggerated contouring of the calf and much less inflammation as a result of the venous reflux. And just to compare, lymphedema has the exact opposite, which we'll talk about. It has the lack of contouring of the calf, and we'll talk about lymphedema in just a little while. So what can happen as a result of venous reflux? Well, you can get clot formation. So because of those leaky valves, there's sluggish flow, and the sluggish flow through the veins can cause, a clot, and it can either be in the deep vein or in the superficial vein. So when you get a clot in the superficial vein, it kind of looks like this. It's very painful and tender on the skin, and you can palpate cords, little palpable cords on the skin. When it's in the deep vein, then the whole leg swells up, as you can see. So because there's lack of return of blood through the leg because of obstruction of the deep vein, and that will cause the whole leg to swell up. As a result of venous reflux, it's not uncommon for people to have a varicose vein that ruptures and bleeds. And this is This is an example of a varicose vein that bled. It's usually in the shower because the moisture from the shower kind of maybe loosens up a little clot on top of a varicose vein and it can bleed. And when this happens, you want to hold direct pressure and you want to elevate your legs, okay? Hold pressure and elevate. That is, and obviously then go to the emergency room, but you want to, the first thing you want to do is hold pressure and elevate. A lot of people just freak out because they see the blood, and it's a very easy thing to fix if you just know what to do. So again, hold pressure, elevate the leg above your heart, and hold direct pressure with it. You can use anything, a washcloth, Kleenex, paper towel, toilet paper, doesn't matter. Just grab your shirt and hold pressure, but just hold pressure over the bleeding site. And venous reflux can cause that. So what is venous reflux? Venous reflux is when there's a reversal of flow in the veins because the valves are damaged, okay? So how do we diagnose it? Well, we do an ultrasound. This is called a duplex ultrasound using a special mode, duplex, which is spectral wave. So we have two different modes. We have the B mode here, and then we have the spectral wave mode here. And so this gives us an idea of what the velocity of the flow is and the direction of the flow per time, okay? So let me show you how that works. Essentially, we do a lot of these studies to diagnose, and here we squeeze the calf muscle, and you can see that the flow here goes in the wrong direction toward the feet, all the way, a very, very long duration of reflux. So many, many seconds of venous reflux. So when you squeeze the calf muscle, you can see the blood go up right here, and then you see this is the flow going back down toward the feet, okay? And that's how we diagnose venous reflux. It's actually pretty simple. So let's see here. So after we do the study, then we draw like a two-dimensional map of the vein. Here's a two-dimensional map with these varicose veins, and this is the map that correlates with this patient's exam. You can see these veins that are coming down, and this patient has reflux through this great saphenous vein, which goes all the way up and it empties into the deep vein up here. So this is the great saphenous vein, which is a superficial vein. This is the small saphenous vein, and that vein is not refluxing. There's a little tiny perforator vein that is refluxing, but the main source of reflux is right here in the great saphenous vein, and the vein map is very helpful to guide what kind of treatment that we would offer this patient to alleviate their symptoms. So this is the vein map, and this is how we treat venous refluxes. We use either thermal techniques with either microwave energy or radio frequency energy, or laser, which is a light energy. So there's heat energy ways to do it, and there's non-thermal ways. So mechanisms like mechanical chemical catheter that can be used. We also use glue sometimes to actually just glue the vein closed as well. So there's lots of different ways to close down veins. And this is an example of radiofrequency ablation, where we use the ultrasound to gain access to the vein. In this case, it's the great saphenous vein, which is the more common vein that usually has reflux. And then we infiltrate in this area around the vein lots of local or tumescent anesthetic. And then we just simply deliver, like every 7 centimeters, we deliver microwave energy, also called radiofrequency energy. And it just heats the vein just enough so that it damages that inside lining so that the vein doesn't carry blood anymore. Either direction, it doesn't carry blood toward the heart, and it doesn't reflux blood as well because the vein has been damaged. So it does, because we're damaging the vein, it does cause a little bit of inflammation, and it's a little bit uncomfortable afterwards, but usually patients don't even need to take Tylenol, to be honest with you. Some do, but most don't. And it's a pretty comfortable procedure. It's done right here in the office. All again with tumescent or local anesthetic. So there is some little teeny needle pokes that are required to inject numbing medicine around the vein. But it's a very amazing technique because it's revolutionized vein care in that, you know, back before 1999, when this technique was approved, FDA approved, we had to do vein stripping. And I think most of you remember those days. Those were not fun. So the doctors didn't like performing those procedures, including me, and the patients didn't like them either. It had to be done in the hospital. Now everything's done in the office and under local anesthetic. And some people are a little nervous, and if you are, we just give you a little Valium to kind of help cut down on the anxiety a little bit. But but it's a great procedure. So that's how we treat venous reflux disease, is with radiofrequency ablation to treat the longer axial veins. The bulging veins that you see on the skin, those are too tortuous to actually place catheters through, and they're too close to the skin. So those we usually treat with sclerotherapy, or more commonly microphlebectomy, and that's where we actually hook and remove. We make a little tiny incision here, usually only about 2 millimeters, pretty small, and then we hook and remove the veins, and that works quite well. And it's not uncommon for patients to need both a ablation as well as a microphlebectomy procedure, and we'll do that frequently. So what happens with an acute deep vein thrombosis? Well, what happens is there's a clot that occurs, and that obstructs the flow through the vein, and that then causes swelling and inflammation below where the clot is present. Sometimes it occurs because it's provoked by something, either like a long plane flight or some sort of local trauma, and sometimes it's not provoked. The ones that are not provoked by anything are a little bit more worrisome, and it makes us more worried that maybe there is a inherent genetic thrombophilia or a hypercoagulable state where the blood clots more likely to clot because of an abnormal genetic clotting factor. And there's multiple different clotting factors, and if we need to, we can test for a genetic thrombophilia, and there's a number of laboratory tests that we can do to do a thrombophilia laboratory workup. And sometimes we do need to do that, and sometimes we don't. It depends on the situation. Post-thrombotic syndrome is something that we worry about as venous and lymphatic medicine specialists. We worry about that because it's very, very common. About 60% of people that have an acute deep vein thrombosis will, in 2 years, develop symptoms and signs of post-thrombotic syndrome, which is pain, as I talked to you about before, pain and swelling after a clot. And 10% are severe, including they get like venous stasis ulcers and that sort of thing, because the pressure is so high that they get inflammation and ulcerations like you saw earlier. So it's a real problem, this post-thrombotic syndrome, and it's under-recognized. When you go to the emergency room with an acute deep vein thrombosis, you want to get on blood thinners. That is true, and that will help prevent the clot from going up into the lungs and the heart, causing a pulmonary embolism. But you also, one thing that's frequently not discussed is this post-thrombotic syndrome, which is real common. And when you have a lot of symptoms with pain and swelling, then it's good to wear a graduated compression stocking or a Velcro compression garment. And frequently those are not ordered and probably should be. So that's post-thrombotic syndrome. And then this May-Thurner syndrome is probably more common than we recognize, but it occurs because this artery here, which is the right iliac artery, puts pressure on the left iliac vein. It can cause swelling of other veins, and the different arteries can put pressure on other veins, but the most common one is this right iliac artery putting pressure on the left iliac vein. So if this vein can't drain adequately because this artery is compressing it, right here, it's compressing the vein, then what you end up is getting a lot of swelling of the leg, and this patient has swelling of this entire leg, all as a result of this compressive symptom. That can be treated if diagnosed. It's a hard thing to diagnose because ultrasound doesn't show this area very well, but there are ways we can diagnose this condition, and the way it's treated is by putting a stent into this vein to open up the vein to prevent obstruction from that artery pushing on the vein. So now I want to talk about lymphedema. It's not as exciting as venous disease, but it is very important. Unfortunately, I'll just say it outright up front, we don't have a lot of really good treatment, at least surgical treatment like we do with venous disease. But there are a lot of things we can do to really help people out, because this is really common and people really suffer from lymphedema. So first of all, what's the definition, or what is it? Well, it's when the lymphatic vessels are either absent, underdeveloped, or obstructed. Okay, so when there's impedance to the flow through these lymphatic vessels, and when that occurs as a result of inadequate congenital formation of those vessels, it's called primary lymphedema. When it occurs as a result of some sort of secondary event, like an infection or cellulitis or surgical trauma or lymphatic, if you've had a surgeon come in and remove lymph nodes, and then we call that secondary lymphedema. Unfortunately, there's not really good surgical treatment for it, but we do have compression. And this is kind of a depiction of what the lymphatic capillaries look like within the tissues. And those lymphatic capillaries draw in fluid, lymphatic fluid, and then they empty through these lymphatic collecting vessels, okay? All of these lymphatic vessels are can be subject to inflammation and can become damaged. And when they become damaged because of infection or inflammation of any kind, whether it be surgery, cellulitis, infection, trauma, venous reflux can cause damage to these vessels. Then if they don't work properly, then you end up with lymphedema. You end up with fluid in the legs as a result of damage to these vessels, these lymphatic vessels. And this is what lymphedema, this is kind of like a, not advanced, but it's definitely more advanced than just a small amount of lymphedema. So this is a picture of lymphedema, and again, this is the anatomy, and you can see that the vessels are here, the capillaries, and then through your capillaries, there's fluid and protein that all gets reabsorbed by the lymphatic system, these capillaries, lymphatic capillaries. Then that returns that lymphatic fluid up filters through the lymph nodes. Obviously, if you have surgery and you've had those lymph nodes removed, you can see that's a problem. The fluid continues to go up, and it goes up into and empties into the venous system in the confluence of this vein and this vein, okay? So it's part of our circulatory system. It's important, but difficult to treat when it's damaged. So this is Okay, so this is our lymphatic system, and you can see here that there are many tiny lymphatic channels that carry fluid. So this is our lymphatic system. I'll turn the volume down on this one, and I'll just narrate from here. So you can see there's lots of little tiny channels here, okay, and these are the lymph nodes, and there's lots of lymph nodes in the pelvis, and the lymphatic fluid has to go up through these little channels, and they filter and they empty into the vein up here in the neck that we talked about earlier. So this is the venous system when we turn on the venous system, and you can see it as it relates to the lymphatic system. The lymphatic system is green, the venous system is blue, and then the artery system here is red. So this is the arteries bring the blood down through the arteries to the feet. Then the veins bring the blood back. But the fluid that develops into the tissues then gets collected by the lymphatic system, and that's this system. And this system brings the fluid, the lymphatic fluid back. So if these lymphatic vessels aren't working properly, then that's when you end up having lymphedema. So I'm zooming in here to show you that up in this area right there is where all of these lymphatics of the whole body end up draining right into the confluence of this internal jugular vein and this subclavian vein. So you can see, if I stop moving around here, right here is where the lymphatic system drains into the venous system. But again, along the way, it goes through multiple lymph nodes. And anytime you've had trauma, again, surgery, venous insufficiency, or inflammation from venous insufficiency, that can cause lymphedema. In fact, when we get one of the most common reasons people get lymphedema is because of venous insufficiency, because all the inflammation can damage the lymphatic vessels. They're very small and fragile, and they have little tiny one-way check valves. When they're damaged to the point where they can't function properly, then the fluid can't migrate through these vessels, and patients end up with lots of lymphedema. We call that, when it occurs as a result of a venous problem, we call it phlebolymphedema. So that's the lymphatic system, and again, the primary lymphedema is when it occurs when you're younger, basically, and secondary when it occurs when you're older as a result of some other process. So there's 3 different kinds of primary lymphedema. There's lymphedema congenita, which occurs shortly after birth. There's precox, which occurs, usually before age 35, and then lymphedema tarda, which manifests after that. But when it occurs as a result of some other inflammation or some other problem, like these problems, then it's called secondary lymphedema. So radiation, especially like if you're a male and you've had radiation of the prostate gland, that is a really common reason that people get lymphedema. Surgery, total knee replacement, I see a lot, not all, but I see a lot of patients that get total knee replacements have edema, because that incision that we put along the knee can cause damage to those lymphatic vessels, and you can get lymphedema. Cancer, filariasis is actually worldwide one of the most common reasons, not in the United States or in the Western world, but worldwide it's one of the most common reasons people get lymphedema, because it's much more common in like Asian countries and stuff. So trauma can damage the lymphatic vessels, and it can cause lymphedema. We talked about phlebolymphedema as a result of venous hypertension, and then medications can cause secondary lymphedema too, including tamoxifen. So there's a staging system. Stage 1 is earlier. Stage 3 is bad. It's pretty much, if you've heard of people that have elephantitis, that's stage 3. That's the worst, and I'll show you some pictures of that. But essentially, as it gets worse, it goes from stage 1 to stage 3, and then you can see these are typical pictures of lymphedema. They have this buffalo hump sign here, okay, and that's called a buffalo hump, and then and it's kind of looks like that is the theory, because fluid accumulates in the dorsum of the foot, and it kind of looks like a buffalo hump. So that's what we call a buffalo hump. And these are other clinical features of lymphedema. You can see, let's just go through each one of these. Let's see. So you see exaggerated skin creases in the toes, and that's characteristic of lymphedema. We see squaring of the toes, kind of looks a little square, more so than usual. And then there's this hypoplastic toenail that occurs as a result of lymphedema. And we don't know exactly why all these occur, but there's the loss of the normal contour, like I was telling you about before, of the mid-calf and the foot. With venous insufficiency and chronic venous insufficiency, where you get that lipodermatosclerosis, you get that bottleneck deformity, it comes down, you get exaggerated contouring of the calf. This is you lose that normal contour. The normal contour that you get, it's actually lost. And so these are the characteristic clinical features on exam of lymphedema. When it's primary lymphedema, you get sometimes it's the ski jump nails. You can see it kind of looks like a ski jump. And if you see that, it sometimes can indicate that it's actually primary lymphedema and not secondary. There's the Stemmer sign. There's Dr. Stemmer. I believe he's Dr. Stemmer. And when you have the inability to pinch the skin of the second toe, like here, the skin cannot be pinched because it's so full with lymphatic fluid. That's a positive Stemmer sign. Okay, that suggests lymphedema. Negative Stemmer sign is you can pinch the skin of the second toe. So obviously this is going to be a positive Stemmer sign, and that's elephantitis stage 3 with more advanced features of lymphedema, and then and this is obviously going to be a negative Stemmer sign as well. That's going to be so in stage 3, which is the worst stage. You get a lot of inflammation, and you get this hyperkeratosis and fibrosis induration. We call it cobblestoning. And sometimes there's active ulcers, open wounds that occur as a result of the stretching of the skin. It's a pretty miserable and disabling condition, I will say, when it's more advanced. So we want to do all we can to really treat it early before it develops into the stage 3. So, folks are, they become, kind of isolated, and it's depressing. So you get depressed. It's not a fun thing to have. You can't work as well. You can't move around as much. So it's it's a very serious condition, and we need to find a cure. Unfortunately, as this depiction says, there's no cure, and it seems like there's not even a race for the cure. Compression helps, but it doesn't. There's no definitive surgical cure for this, like there is with venous disease. But compression is the mainstay of treatment, and there's all different forms of really good forms of compression, so I don't want to be too pessimistic. And we help patients with this. There's compression stockings, okay, and there's all different types of compression stockings. There's good, bad, and the ugly truth about compression stockings. As most of you who have worn compression stockings know, they can be very difficult. Sometimes you can't, if you've got a large belly, you can't reach your feet to put them on. And if you don't have anyone that lives with you at home, you're out of luck, right? So sometimes they're too tight to don. Donning and doffing. Donning is putting a stocking on, doffing is removing it. And if they're too tight, sometimes they can be too tight to put on or to take off. But you need that compression to be therapeutic. So even if you have a helper, sometimes it's not even easy for your helper or your spouse or your whoever is willing to help you to do this. So it can be a challenge. Sometimes they slide down. They can kind of bunch up behind the knee and cause a tourniquet effect. So stockings are good, but stockings are not the only option. I really like these Velcro garments for patients that have more advanced edema, especially just something as simple as this, which is a Velcro garment, because they're easier to put on, a lot easier to put on, and they provide a lot higher compression too. So you can titrate up the amount of compression, and if it's too tight, you can just unvelcro it and loosen it a little bit, so you don't have to take the whole thing off. Some people with stockings, they get frustrated, so they just take it off and they stay in the drawer, and they're not going to do any good if they're in your drawer or in the garbage can. So even though these are more expensive, they usually are a better option for patients with more significant swelling complaints. Then as things get more advanced with significant lymphedema, then we start to recommend pneumatic compression or lymphedema pumps. And this is an example of a pump. And these are great. They do help patients significantly. The only downside of lymphedema pumps is really the time that it takes, because you have to be plugged to a machine. This is not battery operated. You have to be hanging out here reading on your iPad. And then the expense. Insurance is notoriously bad about covering these. So it's very challenging to get insurance to cover these. But they do help, so we recommend these. And then there's manual lymphatic drainage or lymphatic massage. And there's lymphedema specialists that help with this. There are surgical options, like some surgeons have attempted and tried, and there's been some limited success with lymphovenous anastomoses to help, but this is still, pretty far and few between, and the results are not really good. So we're done with lymphedema. Now I'm going to talk about kind of an interesting condition called lipedema. And lipedema is not really edema. It's more considered a maldistribution of fat rather than actual tissue edema or fluid within the tissues. And it goes from stage 1 to stage 3, the smooth, the uneven, and the nodular forms. It's always in women. It's always bilateral. You always have ankle sparing. An ankle cutoff sign is always present. There's typically an incongruence. There's a it'll be in a female, and she'll have a pretty normal looking waist or a thin waist relative to the trunk. So it's truncal to extremity incongruence or mismatch. This would be the lipedema grade 3 because involving the entire thighs as well as the legs with ankle sparing. So that's maldistribution of fat, and it's almost, like I said, exclusively, well, it is exclusively in women. It used to be called painful fat syndrome because when you palpate the skin, it's tender. First described in 1940. It's typically familial, so a woman will have it. Typically her mom and her grandmother, maternal grandmother will have it. That's the typical pattern. Women, siblings, if you have it, if a woman has it, her sister typically would have it as well. So you always want to ask about, family history. It's pretty common and it's grossly underdiagnosed. A lot of people don't know about this condition, but it's not something that's, again, with just like lymphedema, it's even worse in a way because there's not good treatment for it. There are a couple surgeons, one in Los Angeles area, one in Germany, that does these bigger surgeries and actually does a form of liposuction and removes tissue and that sort of thing, but it's not for the faint of heart. So the treatment is not good. Compression doesn't help, but it's good to know what it is, that you're not crazy. It is a known condition, and that's called lipedema. So nonetheless, so now there's nothing to say that all these different causes of swelling occur in isolation. In fact, it's very, very common for there to be multiple causes or etiologies, and we call these hybrid causes, okay? So this would be a patient that has features of, you can see the exaggerated contouring of the calf, okay, and that would be suggestion of venous disease, like with the lipodermatosclerosis. But then you're also getting a little bit of a hint of a buffalo hump thing here going on. So this would be called phlebolymphedema. So this patient has both lymphedema and venous reflux, and we call that phlebolymphedema. One of the more common reasons people get lymphedema is because of venous reflux. Phlebo means vein. So the other thing I want to show you is this bottleneck sign again. This is typical of lipodermatosclerosis, but this abnormality here, where you have lack of contour, not exaggerated contouring, but lack of contouring of the calf, is all typical of lymphedema. And so we have another hybrid, which is a patient like this who has the ankle cutoff sign, typical of lipedema, but they also have extensive, buffalo hump sign here and extensive tissue within the entire calf and thigh, and so we would call that lipolymphedema. This is a lateral view, and then this is a patient that has first developed chronic lymphedema, and then went on to start having more fatty deposition, so we call that lympholipedema. Here is a patient that has lipedema with ankle sparing and then went on to develop venous reflux, so she has lipophlebedema. Okay, so that's a hybrid. And what is this one? This one, it's the quiz of the day. So what do we got? We got this incongruence of the legs and the trunk. So that's a mismatch. So that would suggest lipedema, right? And then there's abnormal fat deposition, there's hemosiderin pigmentation, which goes along with venous disease or venous reflux, and massive localized lymphedema. So that one, as you can guess, is all three. So lipo, phlebo, lymphedema. So there's nothing that says you can't have mixed causes. And in addition to all of those causes, there's all the other heart, lung, liver, kidney issues as well. So it gets complicated. So how do we assess patients? And you can check for pitting. You can see when you push your finger into the tissue here. When you release that pressure, the pit persists for a few minutes after that. And these are the types of questions that I ask my patients when they come in with swelling complaints. And so it would behoove you to look over some of these types of questions to help guide what we can discuss about in the office, and the duration, whether it's bilateral or unilateral. These are things I want to ask because it puts the cause into different, and the treatment into different categories. If it's painful or not, a deep vein thrombosis is typically painful, whereas lymphedema typically is not. Is it intermittent, persistent, progressive? Is there any local recent or past trauma? And that can cause a lot of, can cause swelling for a lot of reasons. It can induce a thrombosis, it could cause a provoked deep vein thrombosis, or it could also cause just bruising and a hematoma with swelling. We saw that earlier too. So I always want to look at your list of medications. I look for amlodipine and all these other medications that can sometimes contribute to swelling. I look for systemic disease, heart, lung, liver, kidney problems, as we discussed earlier. I look for history of previous surgeries, total knee replacements, radical lymphadenectomies from previous prostate surgery or uterine surgery, radiation for prostate surgery or uterine surgery. Those are really common reasons people get lymphedema. And then I look to see, is the swelling worse with gravitational changes? In other words, if you elevate your legs, is it better or worse? If your legs are in a dependent position, does that make it worse as well? And that helps me figure out what's going on as well. So, and then on exam, I look for all of these things. I look at the weight issues. That has a lot to do with it. As we discussed, I look for signs of systemic disease, as we talked about, looking for all those heart, lung, liver, kidney problems. And then I look for that incongruence. I look at the trunk to extremity incongruence or congruence. I look at the abdomen. I palpate for tenderness, look for varicose veins. I look for chronic signs of venous insufficiency, which are the pigment changes, the lipodermatosclerosis, remember the exaggerated contouring, the bottleneck deformity, and venous eczema. There's a lot of inflammatory conditions that occur as a result of venous disease. And then I look for pitting, and I look for that Stemmer sign and all the things we talked about when we talked about lymphedema. So that's what we look for, and it makes a difference whether it's bilateral swelling or edema, or whether it's asymmetric, or whether it's only unilateral. Because if it's bilateral and it's equal in both legs, and usually there's some sort of systemic disease going on. They've got, the patient has a heart problem, congestive heart failure, heart, lung, liver, kidney problems, medications. Maybe it could be a mechanical central obstruction, but that's less common. If the inferior vena cava is obstructed, but that would be less common. It can be bilateral, but then the swelling can be bilateral, but then it's worse on one side than the other. And that's when you start to get into these mixed things where maybe the patient has a little bit of lymphedema, but then they also have congestive heart failure. So they may have congestive heart failure, but then their lymphedema or their venous reflux may make the left side worse than the right or something. So there's nothing to say that you can't have both a systemic thing going on as well as a localized thing going on in one leg. If it's just purely unilateral edema and the symptoms are only on one side and the other leg is completely normal, it's much more common to be either a vein problem with reflux or obstruction, or a lymphatic problem, lymphedema. So family history, this is my last slide too, by the way, so I hope you ate a lot of popcorn. We look for conditions that have a familial propensity, like deep vein thrombosis. If you have a thrombophilia, sometimes those run in families, people with factor V, Leiden, heterozygosity, there's certain factors. There's protein S, protein C. There's a whole bunch of factors in our blood that if they're elevated or low can increase the risk of clot formation. And so we look for, I always take a good family history to determine that. And then if the patient's family has had previous venous reflux, that's also, there's a huge genetic predisposition to varicose veins and venous reflux. Usually about, if one parent has had venous reflux disease, there's a 49% chance that the offspring or the son or daughter will have it. If both parents have venous reflux disease, it's like 89% chance, so real high. And then lipedema is very familial in that it's always passed on from mother to daughter, not to the sons. The men don't get lipedema. And then it's not fair, I know. And then there's congenital lymphedema, as we talked about, with primary lymphedema. So I take quite a bit of a family history. So that covers, I hope, demystifying swelling. It is a complex topic. I am sorry that this was so long, but I hope it helps you understand all the different things that cause swelling and edema, and the things that we can do and the things that we can't do with regards to diagnosis and treatment. So now we have something to talk about when you come to the office. So we look forward to seeing you. Thank you. Dr. Hopkins signing off.